Today I will share 8 bad lab habits we need to stop in the hospital. Some of these labs are very helpful in making or confirming a diagnosis but don't need to be trended, and others are just ordered daily out of habits when they don't change management. Let's get started. The first one, trending ammonia for hepatic encephalopathy. Ammonia can help support the diagnosis of hepatic encephalopathy, but normal levels do not rule it out. Once you make a diagnosis of hepatic encephalopathy, trending daily ammonia level is not reliable to monitor response to treatment. Mental status is the only real way to monitor encephalopathy. The key message here is stop chasing ammonia numbers, follow the patients, not the labs. Remember that you can receive a summary of this video sent directly to your email by subscribing to my Substack newsletter. The link is provided below. The next lab is daily lipase or amylase in acute pancreatitis. Lipase and amylase are part of the criteria for diagnosing acute pancreatitis. But once the diagnosis is made, daily trending tells you nothing about recovery. Abdominal pain is your best predictor, as worsening pain means worsening pancreatitis, and the opposite is true. Now, rarely some people they don't have abdominal pain, and that's rarely to be encountered. The key message here, order lipase and amylase once, not every morning. The next lab is serial BMP in heart failure. BMP is commonly used in the diagnosis and risk stratification of heart failure. However, it's not reliable for monitoring disease progression or response to treatment. So stop ordering daily BMP and rely on your clinical assessments like daily physical exam, daily weight, response to diuretics in terms of INOs. The same applies to NT-proBNP. The third lab we're going to talk about today, AST and ALT in hepatitis. While elevated aminotransferases are common in acute hepatitis, they can be normal or minimally elevated, especially early in the disease or in atypical presentations. If they are elevated, the severity of elevation does not correlate with the severity of hepatitis. AST and ALT indicate hepatocellular injury but do not measure functions or predict outcome reliably. INR and bilirubin levels do, on the other hand. So don't order daily AST or ALT or LFTs. Please do not delay, very important, which I see common, do not delay your patient discharge because ALT and AST remain elevated. They may lag behind for weeks. Focus on clinical stability, resolution of symptoms, and normalizations of synthetic function with INR, normalization of INR and bilirubin instead. The next one we're going to talk about daily CBC, CMP, magnesium, phosphorus, just because. These are often ordered out of habit. I've even caught myself doing it. These labs should only be ordered when the results are expected to change management. For example, in cases of active bleeding, hemodynamics instability, severe infections, critical electrolyte disturbances, acute kidney injury, tumor lysis syndrome, etc. Use your clinical judgment and avoid ordering them just for the sake of ordering. The next lab we're going to talk about today is serial troponins after PCI is performed in acute MI. Now, serial troponins are essential for diagnosing acute MI, but do they add value once the diagnosis is made and the patient has already undergone successful PCI, percutaneous intervention? Current guidelines from major cardiovascular societies do not recommend routine serial troponin measurements after PCIs in patients with a confirmed myocardial infarction. Now, still, some cardiologists continue ordering them because troponin levels correlate with infarct size, LV dysfunction, and adverse outcomes, though in practice, this information rarely changes management. I personally do not order further troponin levels in such a case unless the cardiologist asks for. The next one, we're going to talk about daily INR in stable patients on warfarin. Now, unless you are reversing INR because of a bleed or worried about a major drug interaction or monitoring severe liver disease, avoid the temptation to order daily INR. Guidelines recommend checking INR every few days during initiation or dose adjustments, and then every 4 to 6, sometimes 8 weeks once the patient is stable. Ordering it every morning just because adds discomfort for the patient and waste resource, of course, similar to daily CBC, CMP, magnesium, phos. The key message here, check INR when it matters, not out of routine. And let's finish with ordering daily CRP, ESR, procalcitonin. Trending these values rarely change management, remember that. In the end, if you like this video, I'm sure you will like my previous video on elevated troponins, is it MI or not? The link is provided below. Remember that, again, you can receive a written summary of this video directly in your email by subscribing to my Substack newsletter or my Substack page. The link is provided below. Thanks for watching, and I'll see you soon.